This is my disclosure. I will discuss about the environment of the patients and the improvement in the knowledge of guidelines and why it is important to have this knowledge. These are my disclosures. I will first start with other questions. The first one is, are you familiar with the antiemetic guidelines and do you use them? The response number one is, yes, I'm familiar with the guidelines and I use them. Number two is, yes, I'm familiar with the guidelines, but I don't use them. Why we will discuss at the end of the session. Number three, no, I'm not familiar with the guidelines, and it's because you attend this session, so you're at the right place at the right time. Number four, I do not need the guidelines because I make my own decisions. Why not? And number five, I'm not familiar with the guidelines, but I'm keen to be informed, and it's why you're here also. So you vote, and the answer is, for 50% of you, yes, I'm familiar with the guidelines and you use them. And for the other one, I'm sure that at the end of the session, we will be 100% of us to say, yes, I'm familiar with the guidelines and I will use them. Okay, we move forward to the patient case. Jeannette, a perfect surname from France. She's a French woman. She's 54 years old. She's married, has 2 daughters. She has no comorbidities. She smokes. No morning sickness, she sleeps well, she has no medication use, no anxiety, she has a lung cancer with an early stage, with a resection margin R0, a decision for adjuvant therapy with cisplatin and vinorelbine for 4 cycles. Then the proposition by the multidisciplinary team for supportive care and cancer proposed NK1 receptor antagonist plus cetron plus steroid regimen. What is your advice? She will receive this triple association regimen. Do you agree with this because it's consistent with the MASC-ESMO guidelines? Do you agree it is consistent with ASCO guidelines? Do you agree it is consistent with your local guidelines? You disagree because NK1 inhibitors are not necessary for this indication. You disagree because you follow your local guidelines, and you agree with both 1 and 2, I mean MASC-ESMO guidelines and ASCO guidelines. The next case is Morissette. So Morissette is a Swiss woman from Matia Pro. She's 68 years old. She's married with 1 daughter and 3 granddaughters. Her symptoms include postpartum blues following pregnancies, nausea, bad mood, insomnia, anxiety with chemotherapy. She consumes alcohol daily. She has a diagnosis of ovarian cancer with peritoneal carcinosis, BRCA negative. She will receive a chemotherapy regimen with carboplatin and paclitaxel for 6 cycles, and she will receive, because of the proposition of the multidisciplinary team for supportive care and cancer, a double association with cetron plus steroids. What is your opinion? You agree because it is consistent with MASC-ESMO guidelines. You agree because it is consistent with your local guidelines. Number 3, you disagree. You follow your local guidelines. You disagree it is not consistent with MASC-ESMO guidelines. You disagree NK1 inhibitors are necessary for this indication, or both 4 and 5. And the answers, okay, the majority is you say both 4 and 5, so you disagree, it is not consistent. You're right, because we have to use a triple association for patients under carboplatin with NK1 inhibitors plus cetron plus steroid. Okay, why shall I say that? Because we have today very perfect guidelines published by the MASC-ESMO. As you can see on that side, this is the summary of the acute setting, and we have to use for patients with HEC, highly hematogenic chemotherapy, cisplatin-based or AEC anthracycline cyclophosphamide-based, the triple association cetron plus dexamethasone plus NK1 inhibitors. It's exactly the same for carboplatin regimen. For patients under other MEC, except carboplatin, we only have to use the association with cetron plus dexamethasone. For patients with low hematogenic chemotherapy, you can choose a cetron or dexamethasone or domperidone, and minimal no routine prophylaxis. I move forward to the delayed phase. To the delayed phase, you can have here the summary. For HEC, you don't use anything else than dexamethasone, except the use of aprepitant, and if you use aprepitant, you can decide dexamethasone or metoclopramide. For patients under AC regimen, you don't use dexamethasone, but you can have the choice between dexamethasone or aprepitant if you use it in the acute phase. For carboplatin regimen, you don't have to use anything except aprepitant if you have used aprepitant 125 milligrams at D1. And for patients with oxaliplatin, anthracycline alone, cyclophosphamide alone, dexamethasone can be considered. You don't use anything as routine prophylaxis for other patients under moderate, low, and minimal chemotherapy. Are we following the guidelines, and why are we following them? The first answer is, please go to this publication, The Effect of Guideline-Consistent Antiemetic Therapy on Chemotherapy-Induced Nausea and Vomiting. It was the peer study published by many great leaders involved in the setting of nausea and vomiting, as Mattia Pro, Mario Di Cato, Alexander Molastotis, for example, and Foster Roila. As you can see on that side, there is a real huge impact on the follow-up or the non-follow-up of the guidelines. If we use correctly, if we follow correctly the guidelines, there is an impact in terms of complete response, and it's a significant result compared between consistency or inconsistency use of guidelines. And what does it mean in the daily practice? It means that if you're an oncologist, you will receive more patients in a visit, and you will have more of your patients at the emergency department with a significant result comparing the two cohorts. So please use the guidelines, and first of all, you have to get the knowledge, the perfect knowledge of these guidelines. We don't use guidelines probably because there is a gap of perception between what we think and what the patient really live with the chemotherapy, the anti-cancer treatment. You can see that there is a gap specifically in the nausea and vomiting setting, comparing patient-reported and clinician-reported, with a higher grade for the response of patients. We have this very old study by Steven Grunberg. Steven Grunberg has published those results, very important, because you can see that in the acute phase, we have the same perception with our patients, between nurses, physicians, and nurses. But what appears is that in the delayed phase, the gap will appear with a 30% gap between patients living and physicians' perception. So you can see that this is really important to focus on the delayed phase, because it is a time when the patient went back home and is alone with his medications and don't know what to do. So the use of guidelines recommended antiemetic agents in practice, and I want to present you the one result of the Clark-Snow study. Rebecca Clark-Snow was one of the leaders in antiemetics and involved in the mask workshop. You can see that for the HEC, 90% of us don't use NK1 inhibitors as primary prophylaxis. And you can see that in day 2 and beyond, patients will receive 80% of patients will receive cetrons. We know that we have to use NK1 inhibitors at day 1. We don't have to use cetron at D2 and beyond. What about the MEC? In the MEC setting, you can see that many of patients will receive cetron plus steroids. Only 23% of them will receive NK1 inhibitors. We know that 100% of our patients have to receive cetron plus steroids, and in the carboplatin setting, they will have to receive an NK1 inhibitors associated to the 2 other drugs. The awareness and the use of antiemetic guidelines. This is a European survey presented by Pascal Lilienseger from Gustave Roussy Hospital in France. And it's a very interesting study because we can see that nurses are really familiar with the guidelines. 46% of them with ASCO guidelines, 40% of them with mask guidelines, NCCN and others, but 41% with individual guidelines. What are the guidelines used? The guidelines used are, first of all, individual guidelines. And you can see that the barriers interfering with the implementation of the guidelines is first physician preference. So you have many nurses involved in supportive care, involved in nausea and vomiting fight, and they cannot do anything because our preference is our guidelines. We have to get, once again, the knowledge of the international guidelines validated, published, and we have to use them. So if we move to the results in Europe, in 5 West countries, I mean France, UK, Germany, Spain, and Italy, you can see that the emetic risk category based on the MASC ESMO level score is for the HEC 26% of patients, for the MEC 40% of patients, and for the LEC 34%. The results are about the NQ1 inhibitors use in common chemotherapy in the acute phase, a growth up of the use of NQ1 inhibitors in the carboplatin setting, moving from 14 to 23%. It's very good because we will be in 10 years confident with the guidelines, with the current guidelines, but you can see that in the cisplatin and AC regimen, we only have around 40% of patients receiving NQ1 inhibitors. We should prescribe NQ1 inhibitors to 100% of our patients, so we're missing for 60% of them. What is our perception? Because the gap is probably the perception of the physicians, of the prescribers, of the antiemetic prophylaxis. What is the physician's What is the physician's perception on emetic risk and the NQ1 inhibitor use? You can see that if you ask the physician, they consider for 40% of them that cisplatin plus pemetrexed is not a high emetogenic chemotherapy. We know that cisplatin will put this regimen in the highly emetogenic chemotherapy class. You can see that it's the same for cisplatin gemcitabine, and if we move to carboplatin, it's exactly the same. We consider, for majority of us, that carboplatin is not a HEC. No, it's not a HEC, it's a MEC, but it's a MEC that needs to get a prophylaxis with a triple association as well as the highly emetogenic chemotherapy regimen. What about the emetogenicity of common chemotherapy agents and the underestimation? If you consider that cisplatin plus pemetrexed is not a HEC, so you don't deliver the right drug, you don't deliver the triple association, and what is presented in that slide, it means that only 80% of us will prescribe it if we consider this regimen with cisplatin as HEC, and only 34% of us will prescribe NQ1 inhibitors if we consider not as a HEC. It's the same for carboplatin, it's the same for AC regimen. So what about the NEO study? We were in the west of Europe, we are moving to the east of Europe, and the NEO study is a multi-center non-interventional prospective study which objective and outcomes are to assess the impact of adherence to antiemetic guidelines in patients receiving repeated cycles of either HEC and MEC, and the primary outcome is the complete response, and the secondary outcome will be the effect on quality of life. So you can see on that slide, on that map, the different centers involved in this interesting study with Austria, Helovin, with Bulgaria, Czech Republic, Hungary, Poland, Romania, and Slovakia. And the number of patients currently enrolled is above 700, with above 80 clinical seats open. So what about patient-related characteristics? First, why do patients not report nausea and/or vomiting? It was a publication by Cheryl Vidal, presented 3 years ago at a MASC meeting in Copenhagen. And the first answer by physicians, nurses, and patients is, I accept that nausea and/or vomiting is a normal side effect of chemotherapy, radiotherapy that has to be tolerated. My answer is no. We don't have to agree with that answer. We have to fight against nausea and vomiting. It's not normal. Patients will have to focus on sexuality, on daily living, on daughters, on eating, and not on nausea and vomiting. So we have to use the right drug at the right place for the right patient to avoid any nausea and vomiting. And it's because was published this very terrific paper by Dranil Zaris and other leaders to develop a prediction tool to assess the individual risk of our patients in terms of nausea and vomiting. And this is the risk table, the risk scoring algorithm, and you can see that the impact of patient risk factors is first the age with a 0.1. Patient expects to have CINV. Patient slept less than 7 hours the night before chemotherapy. So remember the question, one of the first question about sleeping before chemotherapy, the history of morning sickness, the level of hematogenicity of the chemotherapy regimen, and the prescription at home that the patients have available, the nausea and vomiting in previous cycle, and what about the second cycle, third cycle, etc. There is a cutoff at 16, and then we can have this editor that I published in the same issue of Annals of Oncology, is that maybe in the future we can upgrade our patient from MEC to HEC, or from HEC to very HEC regimen, and then maybe add a new drug. If you start with an association with cetron plus steroid, then if the patients have several risk factors, you can add the NQ1 inhibitors whenever the patient has a LEC or a MEC. And if the patient has a HEC, following the MASC-ESMO guidelines, you have to prescribe a triple association NQ1 inhibitor plus cetron plus steroids. If the patient has several characteristics, you may upgrade this risk and then add the olanzapine or another antiemetic to the triple association. And what is proposed in this very, very good application, and please move to the website to charge it, and you can use it in your daily practice face-to-face with your patient, is to assess the risk score of your patient. So you just put risk-CINV, www.risk-CINV, and then you have the risk factors. And we move back to our clinical cases. The first one is Jeannette, the French woman with 54 years old. She's young, she's married, 2 daughters, no comorbidities, she smokes, she has no morning sickness, she sleeps well, she has no medication use, she has no anxiety, she has a lung cancer with an adjuvant therapy with cisplatin regimen, and she will receive a triple association NQ1 inhibitors plus a cetron plus a steroid regimen. So what we can see on the website is that this chemotherapy is at a high hematogenic level, and we have to prescribe the triple association NQ1 inhibitors plus cetron plus corticosteroids, and it's not necessary to add another antiemetic. Then the last case is Morissette, the Swiss woman, 68 years old. She's married with daughter and granddaughters. The symptoms include postpartum blues, nausea, bad mood, insomnia, anxiety with chemotherapy. She consumes alcohol daily. The diagnosis is an ovarian cancer, and she will receive carboplatin regimen. So the proposition was an association, a double association, cetron plus steroid. The answer, when you put the risk factors in the website, is a high level of emesis, and you have to prescribe triple association NQ1 inhibitors plus steroid plus cetron, and you can add another antiemetic, so a quadruple association. This is what means when you use this risk tool. You can see that it's very interesting because you don't just focus on the level of hematogenicity. You use today the level of hematogenicity of the chemotherapy regimen, but also you use the patient's characteristics. And I conclude on that sentence by Dorothy Keefe and by the MASC. This is our message: supportive care makes excellent cancer care possible. Thank you very much.